Welcome back, everyone, to Part 83 of our CPC Exam Series Explainer. Today, we're jumping straight into the CPT 70010 to 7999 block, and we are cracking the code on diagnostic radiology. Before we dive into these high-yield exam traps, make sure to like, share, and subscribe to Decode Healthcare with Harshal. It seriously helps us keep these explainers coming your way.
All right, here's our game plan for today. 1. Radiology basics and modifiers. 2. X-ray, CT, and contrast. 3. Ultrasound coding exam guidelines. 4. Mammography and bone density. And 5. Our Part 83 summary cheat sheet.
Let's kick things off with Section 1, Radiology Basics and Modifiers. So, mastering radiology coding basically starts with one massive question. Who owns the equipment and who is actually reading the report? See, radiology services usually have two distinct parts. Modifier 26 represents the professional component. You're going to use this when a physician only interprets the image and writes up the official report. On the flip side, we have modifier TC, or the technical component. This one gets billed by the facility that owns the physical machine, pays the staff, and covers the overhead, but they aren't the ones actually interpreting the film. But hey, what if your physician does the whole shebang? Well, that brings us right to global billing. You just build a CPT code without any modifiers when the practice owns the equipment and does the interpretation. So for the exam, you need to literally scan the vignette for the phrase same entity performed and interpreted. If you see that exact wording, think global. Moving on to Section 2, X-ray, CT, and contrast. Let's hit our next major exam battleground. While basic X-rays are usually just coded by the number of views, CT and MRI codes completely hinge on contrast administration. CPT breaks these down into a really strict code selection triad. We've got without contrast, with contrast, and without contrast followed by contrast. Now, here's a trap a lot of people fall for. With and without means a two-phase study. Absolutely never bill a combined code if the documentation only supports a single phase. Okay, if you remember literally only one thing from today's explainer, make it this critical rule. Are you ready? Oral or rectal contrast alone does not equal with contrast for CT or MRI coding. No way. To legally bill a with contrast code, that material must be administered intravascularly, intra-articularly, or intrathecally, period. Don't let the exam trick you just because a patient drank some barium. All right, let's jump to Section 3, Ultrasound Coding Exam Guidelines. Diagnostic ultrasounds are heavily tested on the CPC exam, specifically when it comes to the scope of the scan. You're going to see questions constantly forcing you to choose between a complete and a limited exam. So, a complete scan means the provider attempted to visualize and document absolutely all the major elements listed in the code descriptor. If the provider omits a required organ, even just a single one, you have to code it as a limited scan, or you append Modify 52 for reduced services. Plus, there are incredibly strict compliance rules here. Without permanently stored images and a formal written report that details the findings, the service completely fails professional component expectations. Think of it like this: no images and no report equals no bill. It's really that simple. Almost there, Section 4, Mammography and Bone Density. For these final clinical categories, it all comes down to patient symptoms, or honestly, the lack of symptoms. Notice how the provider's intent completely changes your code selection. CPT 77067 is your screening mammography. This one is always bilateral and it's done on an asymptomatic patient. But let's say a patient comes in with a lump, right? You immediately switch to diagnostic mammography. That's 77065 for unilateral or 77066 for bilateral. Again, intent is everything here. Next up, DEXA scans, which evaluate osteoporosis. Notice the anatomical split we have here. CPT 77080 is used for the axial skeleton, so think hips and spine. Meanwhile, 77081 is specifically for the peripheral skeleton, like the wrist. When you're reading a scenario, you have to pinpoint the exact area of the skeleton being tested. And finally, Section 5, Part 83, Summary Cheat Sheet. All right, you made it to the end of today's deep dive. Let's quickly lock in this knowledge with a high-yield cheat sheet. Here are your 4 rapid-fire takeaways for the exam. First, Modifier 26 is interpretation. TC is equipment. Second, oral or rectal contrast is never with contrast. Just don't do it. Third, diagnostic ultrasounds absolutely require permanently recorded images. And fourth, mammography code 77067 is strictly for screening, while 65 and 66 are diagnostic. You definitely want to burn these into your memory. And that wraps up part 83, but you know we're just getting started, right? Coming up next in part 84, we are tackling the really complex procedural logic of interventional radiology, radiation oncology, and nuclear medicine. So my question for you is, are you ready to conquer the bundling rules of catheter placements? Keep studying hard, and I will see you in the next explainer.